Greetings from Indian Journal of Anaesthesia. I, Dr. Kiran Mahendru, will give you an overview of article published in the July issue of IJA. It is an article on comparison of ultrasound-guided erector spinae plane block with ultrasound-guided pericapsular nerve group block for pediatric hip surgery. It is a randomized double-blinded study. Postoperative pain due to hip repair surgeries in children is a major concern. It requires opioid analgesics with regional blocks. The most frequently used regional methods are the neuraxial blocks, which include caudal and epidural. Erector spinae plane block and pericapsular nerve block is an adjuvant with GA and is known to cause lesser side effects with less motor weakness and PONV with decreased opioid consumption. Now, erector spinae plane is an interfacial plane situated between the erector spinae muscle laterally and tips of thoracic transverse processes medially, whereas PENG is a plane lying between the psoas muscle and the tendon and the iliopubic eminence. This study was carried out to assess the ultrasound-guided PENG block versus the ESP block for their efficacy, safety, and pain management in pediatric hip surgery. The primary objective of the study was to assess the first-time request for rescue analgesia in patients undergoing hip surgery receiving either PENG or ESP block. And the secondary objective was the heart rate, mean arterial pressures, post-operative pain scores, any adverse effects, and parents' satisfaction. Ethical approval was obtained for the study, and the study is registered with clinicaltrials.gov. It is a randomized double-blinded study, which included children of both the genders aged above 1 year, ASA class 1 or 2, scheduled for elective unilateral hip surgery due to hip avascular necrosis, dislocation, dysplasias, or fracture. The patients excluded were the ones with neurological, spinal, or coagulation disorders, any infection suspected or confirmed to be related to the block site, history of allergies to local anesthetics, bilateral or redo hip surgeries, and parents' refusal to participate. All the patients were pre-medicated with oral midazolam 0.5 mg per kg. Standard monitoring was done and basic hemodynamic values were recorded. Inhalational induction was done with 4 to 8% sevoflurane in 100% oxygen. A peripheral line of 22 gauge was taken and an infusion of 7 ml per kg of dextrose 5% and half normal saline was started. IV propofol 1 mg per kg was given to deepen the anesthesia plane. IV 0.5 mg per kg of etracurium was followed by a suitable size endotracheal tube placement. Maintenance was done with sevoflurane 2% in 50 to 50% ratio of oxygen to air and a 0.1 mg per kg of etracurium for maintenance of the neuromuscular blockade. BIS was maintained between 40 to 60 and the ventilation was done to maintain an end-tidal CO2 between 35 to 40. ESP was conducted in a lateral position with the surgical side up using a linear transducer at the L2 level with a 22 gauge 50 millimeter needle to reach the plane lying deep to the erector spinae muscle in a cranio to caudal direction. A 0.5 ml per kg of bupivacaine, 0.25% with ADR 1:2 lakh was given with a maximum dose of bupivacaine allowed being 2 mg per kg. PENG block was given in the supine position using a linear probe. The landmarks were iliopubic eminence, iliopsoas muscle and tendon, femoral artery and vein, and the pectineus muscle. It was given in a lateral to medial in-plane approach in a musculofacial plane between the iliopubic ramus posteriorly and the psoas tendon interiorly. The same amount of drug was given in the PENG block as in the ESP block. The skin incision was given 20 minutes after local anesthetic administration, and a hemodynamic response with more than 20% values going up. The rescue analgesia was given with IV fentanyl 1 microgram per kg. In the post-operative period, IV paracetamol in the doses of 15 mg per kg were given 6 hourly, and if the pain scores, which was seen using the FLACC score, became more than 3, IV morphine in the dose of 0.1 mg per kg was given as a rescue analgesic, with the maximum dose going up to 0.3 mg per kg per day. The primary outcome of the study was the time to first request for morphine rescue analgesia, and the secondary outcomes were the hemodynamic parameters, that is the mean arterial pressures and the heart rate, number of children who required intraoperative rescue IV fentanyl analgesia, that is 1 mg per kg of fentanyl if the hemodynamic parameters shooted more than 20% from the baseline at skin incision, intraoperative fentanyl and postoperative IV morphine consumption, postoperative pain scores using the scoring system of FLACC for pediatric patients, any side effects, and parents' satisfaction. Based on a pilot study conducted by the authors on 10 patients, 23 patients were required in each group to detect a difference in first time of rescue analgesia of at least 75 minutes. Therefore, the required sample size was 28 for each group to compensate for possibility of discarded cases. SPSS 24 version was used for statistical analysis. Total 63 children were recruited, out of which 56 children were eligible for the study, and 28 children were randomly allocated to the two groups, either ESP or the PEN group. The demographic data was comparable between the two groups, which was the age, gender, weight, and the duration of surgery. Now coming to the primary outcome, which was the first rescue analgesia given in hours, there was a statistically significant difference in the first dose of rescue analgesia, where the first dose was required at around 8.39 hours in the ESP group and around 6.64 hours in the PEN group. That is, the rescue analgesia was required earlier in the PEN group as compared to the ESP group. Now coming to the secondary outcomes, the number of children who needed intraop rescue analgesia were comparable. The intraoperative fentanyl consumption between the two groups was also comparable, whereas the post-op morphine consumption was higher in the PEN group when compared to the ESP group. A total of 3.3 mg was required in the PEN group versus 2.8 in the ESP group. The parents' satisfaction score was comparable in both the groups, and the adverse effects seen as PONV, pruritus, urinary retention, any localized hematoma, local anesthetic toxicity, bradycardia, or hypotension were comparable. Now, post-operative pain scores were comparable in the recovery room, whereas at 2 hours and 4 hours post-operatively, the scores were higher in PEN group as compared to the ESP group. At 6 hours, the scores were comparable, and at 8 hours, the pain scores in the ESP group were statistically significantly higher than the PEN group. At 12, 18, and 24 hours, again, the pain scores were comparable. The hemodynamic parameters in the form of heart rate and mean arterial pressures were comparable in both the groups at all the time points. Now, the first time morphine rescue analgesia was significantly longer in group ESP, whereas the postoperative morphine consumption was significantly higher in the PEN group. The group PEN with shorter time to first rescue analgesia at 6 hours led to a greater postoperative pain scores of group ESP at 8 hours. But pain scores of both the groups still did not exceed the FLACC score of 4 at any time point, and no significant difference was seen between the intraoperative opioid consumption. Now, many case reports on both the blocks and a systemic review on ESP in children reported good and effective analgesia with these blocks. These supported the ESP and PEN's intraoperative analgesia in pediatric hip surgery also. The only limitation of the study was the limited sample size, and in addition, motor block could not be assessed due to immobilization by spica casting for 6 weeks. Therefore, the ESP block for pediatric hip surgery could provide a longer first request duration for post-op rescue analgesia with lower postoperative rescue morphine analgesia than the PAN block. But both the blocks provided adequate intraoperative analgesia, showed comparable postoperative side effects, and resulted in comparable parents' satisfaction. Thank you.